Welcome. This is the presentation of our scientific article, Inter- and Intra-Tester Reliability of the Stand-in Flexion Test. Authors Thale, Myhren and Christina Vedsted, Nørrelund. Speaker Christina Vedsted, Nørrelund. Promoter Frederick van Boom. Scientific article to obtain the title DO, Diploma in Osteopathy, academic year 2016 to 2017. In our literature search, we found limited amount of articles regarding the stand-in flexion test, and only 2 articles were found specifically regarding the reliability of the stand-in flexion test, which found fair to moderate kappa values. This implies the relevance for further examination of the stand-in flexion test regarding the reliability and validity in order to achieve clinical precision. Many researchers find it questionable whether the small range of motion in the sacroiliac joint can be palpated at all. The mobility of the SI joint is influenced by anatomical restrictions and biomechanical components. For example, the support and stabilization of the SI joint created by the latissimus dorsi, the posterior layer of the thoracolumbar fascia, and the contralateral gluteus maximus. An asymmetrical tension in this myofascial chain can lead to palpatory illusion, such as larger movement in the SI joint, which will affect the interpretation of the palpated findings and motion palpation test. Another factor that influences the result of motion palpation test is subjective interpretation by each examiner, and low inter- and intra-reliability is found in relation to palpation of the posterior superior iliac spine. The purpose of this study is to test the inter- and intra-tester reliability of the stand-in flexion test. The hypotheses were to see if there were inter- and intra-reliability or not. For this study, we chose an intra-day reliability design, which is found to be a stronger study design than an inter-day reliability design. Prior to the test, the 2 examiners undertook joint practice twice in order to get familiarized with the experimental protocol. This was found necessary in order to ensure that the examiners performed the test identically and instructed the participant the same way. The joint practice also served the purpose of making sure that the examiners only registered the test as a positive when a clear block was present and not when a discussable restriction was at hand. Each participant was assessed twice by each examiner with a 1-hour break in between the tests. 60 participants enrolled in the study, of both genders at the age of 18 to 50 years. The exclusion criteria were injury or pain that affects the ability to perform the test, restriction in movement of the lower extremities or trunk due to hip prosthesis or other surgery, balance or dizziness problems that result in inability to perform the test. The participant received both verbal and written information about the study before the test. Prior to the test, all participants signed a written consent form and could at any time withdraw their participation without questions. During the test, the participant stood barefoot facing away from the examiner and with a hip width distance between the feet. The examiner sat behind the participant with her eyes at the height of posterior superior iliac spine. The examiner's thumbs palpated the lower point of posterior superior iliac spine from caudal and lifting the skin slack. The participant was instructed to do a flexion in the hips without bending the knees. If one posterior superior iliac spine made a cranial displacement during flexion, the side was noted as positive on either left or right side and marked with either a L or R. If no displacement was present, it was marked with IA. On this picture, a positive test on the left side is shown. Throughout the test, the examiners were positioned with their backs toward each other, unable to see what the other examiner found during their individual examination. Cohen's kappa correlation coefficient was used to define the inter- and intra-tester reliability. It is a standard value and measures the agreement between two raters. It is found to be a more robust measure compared to percent agreement calculation, since kappa correlation takes into account the possibility of the agreement occurring by chance. The Altman classification was used to determine the kappa value once it was calculated for each reliability. The result of the intertester reliability was 0.414 to 0.431 in test round 1 and 2 and was considered moderate. The result of the intratester reliability was found to be 0.607 for examiner A and 0.617 for examiner B and was considered good. The results in this study show a higher inter- and intra-reliability than previous similar studies. This is found to be due to larger sample size, standardization of method, and joint practice sessions. The results can be affected by different causes: remembrance, either conscious or unconscious, tactile sensibility and individual interpretation, or tissue change. In this study, we tried to avoid the conscious remembrance by removing participants from the dataset if one or both examiners reported of remembrance in second test round. This was done in 2 cases. In regard to the individual interpretation, 2 joint practice sessions took place prior to the test in order to avoid any uncertainties and minimize the difference in interpretation between the 2 examiners. The results will always be influenced by tissue tension and individual tactile sensitivity. Since palpatory tests are performed by humans and not machines, the result will always be affected by the tactile sensitivity. Additionally, humans cannot be calibrated in the same way as machines and measuring instruments. The intratester reliability was considered good and the intertester reliability was moderate. Many researchers often accept moderate kappa values in regards to the intertester reliability, but is this acceptable in healthcare and clinical practice? Even if our results show better intertester reliability compared to previous similar studies, we believe one has to be careful in accepting the result, especially if it changes clinical practice in a way that leads to poor patient outcomes. In order to achieve even better results along with higher kappa values, adjustment to the study design could be implemented. More training sessions prior to the test to ensure that the test is done the same way and to minimize difference in interpretation of the findings. Or larger sample size, which will make the results less sensitive to disagreement between the examiners. Last, longer breaks between tests, for example in the morning and in the evening, but still keep it as an intraday study, since this is found to be a stronger study design than an interday study. Other issues is the possibility to do a reliability study of a cluster test containing the standing flexion test. Cluster tests are argued as a useful tool in testing the SI joint, resulting in better overall conclusions and leading to more reliable results. But it is important to remember that the establishment of a cluster test is of higher value when they include the reliability of the complete cluster test as well as for each of the individual tests within the cluster. The positive results conclude that the standing flexion test can be used in clinical practice, but if more therapists use the test in regards to the same patient, they must be aware of the possible variation in the findings. This study found statistically significant intratester reliability, but no statistical significance regarding the result of the intertester reliability. According to the Altman classification, the kappa values of the intertester reliability is found to be moderate and the HOA hypothesis is accepted. But the study did show a higher intertester reliability than found in previous similar studies. The kappa values for the intratester reliability is found to be good for both examiners and the H1B hypothesis is accepted. Additional research is needed in order to strengthen and accept the reliability of the stand inflection test and to support the findings of this study. Thank you.